Good afternoon, everyone, and welcome to the Shout Texas Echo. That stands for Support Hospital Opioid Use Disorder Treatment. I'm really glad you can all join us today. Note that as you just saw, we are recording these sessions for later distribution. Anything you listen to chat does not appear in that recording. My name's Jananie Ramesh. I'll be facilitating our session today. I have a few quick housekeeping notes before we get started. To help us capture attendance and introduce yourselves to the group you're learning with, please use the chat feature to enter your name, your affiliation, and your email. Access that chat feature by navigating to the bottom of your Zoom window and clicking on the speech bubble in the navigation bar. A special note to all the Be Well Texas providers, make sure you identify yourself in the chat during this session. And if you've joined by phone only, which I don't think anyone has, but if you ever do, email that phone number to the Be Well team at bewelltx@uthscsa.edu. We'll put that email into the chat, and that's just to make sure we know that you're here at these sessions. We do ask that you stay muted unless you're speaking. If you've joined by computer, that mute icon is in the lower left corner of your Zoom controls. If you're on the phone, just press *6 and wait for the loud voice to tell you you're unmuted. We do encourage everybody to speak up in these sessions, especially during the discussion portion, but do allow space for others to speak as well. So keep those comments brief so others can share their perspectives as well. You can speak up by unmuting and sharing your thoughts, or you can also use the chat feature to share your questions, your comments, your experiences. Just note that whether you're unmuting and speaking or communicating over in the chat, no protected health information is allowed in either space during our discussions. Also note that these sessions have been enabled for closed captioning to help with your attendance. Just to access that, navigate to the bottom of your Zoom window and select the Show Captions option. It might be buried under that More menu in the bottom right of your Zoom. If you're having any trouble accessing captioning, just chat with Echo IT. Today's didactic is on counseling patients on initiating buprenorphine therapy, presented by our hub team, our hub member, Dr. Ramesh. And following that, we're going to discuss a case presented by Dustin and Maddie. We're going to start with some introductions followed by those didactics and then some announcements from the Be Well program. And then we'll get into the really fun part of the session, that case presentation and open discussion. So thanks again, everybody, for joining us at today's Echo. As always, we look forward to learning alongside you. Please share your experiences, your questions, and your insight throughout today's conversation. Let's do some introductions. Dr. Ramesh, I'll start with you.
Hi, everyone. I'm Jananie Ramesh. I'm a hospitalist at Dell Medical Center. Excited to be here today.
Thanks for joining us. And Dr. Walker. Oh, you're muted.
I'm so sorry. Hi, it's Blair Walker. I'm with psychiatry in the hub team here at Dell Medical School in Austin.
Thanks for joining us. Dr. Weems.
Hey, John Weems here at UT Dell and Community Care FQHCs and the hub team. Looking forward to the talk and case today.
Great, thank you. Thanks for joining us. And Alana.
Hi, good afternoon, everyone. My name is Alana Bolton. I am a program manager at Dell Medical School and the director of Shout Texas. Thanks so much for being here.
Great, thank you. And let's go over to our case presenters. Dustin, Maddie, I think you're in the same room together, right?
We are in the same room. Hi, I'm Maddie. I'm a PA with the Psychiatry Consult Liaison Service at JPS Hospital Network. Actually, Dr. DeMoss did have to step out for a clinic thing that came up, but he's hoping to be back when we present. All
right. That's totally understandable, and it happens. Patients are the priority. Well, thank you all for joining us for today. This is going to be a great session. At this point, Dr. Ramesh, you have slide share control, so please do screen share and take it away.
All right.
And as she's doing that, just a reminder, as folks are coming in, please do use the chat window to introduce yourselves, your name, your affiliation, and your email. Jan, what I see, if you can switch to that other view, it's still looking kind of odd. It's like that really zoomed in view. Oh, now it looks great.
Okay, great. Can y'all hear me?
Yes.
Okay, cool. All right. Thank you all for joining today. My presentation for counseling patients on initiating SUD treatment. I have no disclosures today. I'm intending for the session to be a general overview on how to talk to patients and respond to patient concerns about starting medications for OUD. Since many of you do this in your day-to-day practice, and we've covered a lot of the nuts and bolts of this in prior ECHO sessions this year, hopefully a lot of this will be kind of a review to you. I welcome y'all's experiences and expertise, so please feel free to interject and chime in with your best practices as well, if you think of them. Distilling down what we know about buprenorphine and methadone to a digestible form for patients can be challenging, especially when they're in the middle of suffering from withdrawal or had traumatic experiences with the medications in the past. And in addition, contextualizing this information within a hostile political environment, a growing overdose crisis, and ongoing stigma around their condition can feel downright hopeless. But I think that framing the discussion around the number of lives saved, celebrating small wins, and fighting the good fight while keeping it patient-centered helps mitigate a little bit of this feeling. Here are the learning objectives for today. Understand how to minimize stigma when counseling a patient on SUD treatment options, explain the differences between evidence-based treatments, and utilize harm reduction strategies when counseling patients. Here are the really very basics of what you need to know about a patient's drug use before coming up with a treatment plan for them. It's a difficult thing for anyone to talk about. So first, ask permission to discuss it with them and let them reserve the right to say no. Ask last use, how much and how often, to get a ballpark idea of maybe the morphine equivalent dosing that might be needed for them in the hospital. Ask about IV administration versus other, since you will have to then check HIV status and assess for other needle-borne illnesses and provide appropriate counseling. Always ask about any co-ingestions, which will be most patients that you see. Gives an idea of other withdrawals that they could be experiencing, like benzo or alcohol, and what extra medications you may need to treat them. Ask about the people and the setting in which they use to identify potential triggers for them and other people in their life who might be in danger of overdose and might want to know this information. And then always ask about prior quit attempts, rehab attempts, and medication trials. Try to understand kind of what did and didn't go well during prior attempts. You can sometimes help correct any misconceptions they may have about the recovery space if they've had some bad experiences with it. And then you can move on to discussing the possibility of treatment. I'm sure most of you have heard a version of one or more of these phrases when treating a patient with opioid use disorder. It often kind of seems like it sets up an antagonistic relationship from the get-go, but these statements are really coming from a place of fear, reacting to years of stigma and poor treatment that's perpetuated by our healthcare system and other institutions. As a reminder, stigma can come from institutions in the form of rules and policies that limit or ostracize the stigmatized group, from negative attitudes that lead to poor treatment, and even from self-stigma, shame and self-hatred from being part of a said group. Multiple studies have found that people who experience stigma from the healthcare system are less likely to stay engaged in care, have lower self-esteem, and often receive suboptimal care on top of it. So this first statement shows the phrase drug seeking, which we all hate. It's a pejorative term assigned to patients who come to the hospital seeking drugs. Most people who come to the hospital do seek drugs, which is the pharmaceutical stuff that we give them. So this is already a silly phrase. And for those with opioid use disorder who present to the hospital, many of them are past that point where their drug of choice brings euphoria, and instead are just trying to stave off pain and withdrawal. I've had a patient, I know you don't care if I die out there in the street. The patient who says this has actually probably seen their loved ones die out there in the street and felt helpless to stop it. They are scared that they're going to end up that way too. All of you are the same. You think I'm just a junkie. So this patient has clearly been dehumanized and othered a lot, and they have been told that their pain and experiences don't matter and that they don't deserve to be treated with the same dignity as everyone else. That's what this statement says. And then you might even hear from some people, I'm not one of those drug addicts. There is a dichotomy that exists even amongst opioid users between the legitimate quote unquote use of opioids for chronic pain and illegitimate use, recreational use. Unlike the illicit opioid use, media coverage of the prescription opioid crisis blamed the pharmaceutical industry and irresponsible prescribing. And so people on prescription opioids are seen more as victims and not morally culpable for their disease. So when this idea is perpetuated in healthcare, the stigma continues to exist even amongst patients and further paints people who use street opioids as irresponsible and making bad choices. So if a patient says any of these statements in a combative way, validate these experiences, acknowledge that they've likely been heavily stigmatized and mistreated in the past, and that you're going to try your best to help them and have a more positive experience today. I'm going to try to frame this lecture around how to counsel patients on SUD treatment based on what stage of change they're at. So we'll go through the pre-contemplative, contemplative, and action-oriented session that might be appropriate for each stage of change. So first we have, regardless of the stage of change that the patient is in, we should remember the guiding principles of motivational interviewing to help us guide the conversation. Motivational interviewing is a form of counseling that's designed to elicit a behavioral change by activating a patient's own motivators and desire to be involved in treatment. The way you talk to patients can substantially alter their motivation to change. Remember, there's 4 guiding principles of MI, and the acronym spells out RULE. R stands for resist the righting reflex, which is the reflexive urge to correct someone's actions. This is how we've been taught and trained as healthcare providers. It comes as no surprise that patients hate being lectured at, and it's natural for them to try and resist being persuaded. So when confronted with the suggestion to cut down and give reasons not to change, especially with people who suffer from opioid use disorder, who have likely already had some less.
Looks like we may have lost Dr. Ramesh. Let me get just a second here and we'll try to get her back. Dr. Ramesh, can you hear me?
Hello, can you all hear me?
Hi.
Yes, I can hear you.
We
I do
lost
not
you.
know what happened there. I'm sorry.
It's okay. It's Zoom just keeping us on our toes. I hear you loud and clear. Carly has shared your slides. Do you want to just proceed from here?
Yes, give me 1 second. Sorry.
And I know it interrupts the flow of it a little bit. We'll just have you say next slide.
Yes.
Your voice is more important than you trying. Thank you. Take it away when you're ready.
Okay. Oops. Okay. Yeah, you can press so the rest of the thing shows. So with R, it's a resist the righting reflex. U stands for understanding the patient's motivations. Patients are going to change according to their own motivators to change and values, not necessarily yours. L stands for listening, and E stands for empower. Patients do better when they take an active interest in their health and treatment plan, and you as the clinician can support them in realizing how they can facilitate and sustain the behavior change. They're the experts on their own life. And this is really important when it comes to choosing a treatment plan, buprenorphine versus methadone, for opioid use disorder, because whether a patient's preferences are respected or not can dictate whether the treatment is successful, if a therapeutic alliance is established, and if the patient stays in treatment. Next slide, please. So with that, here's what you would talk about with a pre-contemplative patient: harm reduction. Oops, sorry. Acknowledge, I think it's may have skipped a slide. Oh, well. So it's important to discuss harm reduction for them to stay safe. We're a little limited here in Texas because of some of the services officially being illegal, but the Texas Harm Reduction Alliance can help patients in other ways. First, naloxone. It can be purchased at participating pharmacies without a script, although the brand Narcan can be quite expensive if you are not insured. It should be prescribed at discharge to patients with all use disorders, not just opioids, even those who are at high risk of opioid toxicity due to prescription opioids for chronic pain. Naloxone, as a reminder, can revive people who are experiencing overdose due to opioids by restoring the respiratory drive. Ideally, a family member or friend should receive the education about naloxone too, and the patient should be advised to never use alone. I believe now we have an naloxone vending machine here in Austin, and local harm reduction orgs are working to increase access to this drug to the most marginalized groups. There may be some dialogue that you may have heard around naloxone not working as well in the fentanyl age, leading to some buzz in the press around the necessity of high-dose naloxone like Cloxato and Zimhi. The evidence that high-dose naloxone is more effective at restoring that respiratory drive is just not there. High-dose naloxone can actually worsen and protract the withdrawal symptoms a patient experiences when they wake up, as well as increase agitation and symptoms like vomiting, so use it judiciously. Reassure patients that standard dose naloxone still does work on fentanyl overdose. And if you've had the experience that it's not doing enough in that situation, it's likely that co-ingestions of things like benzos and alcohol are playing a role, or contamination from xylazine or other adulterants, or even other reasons such as electrolytes, brain injury, and hypothermia, all of which can lead to sedation and don't respond to just naloxone. So remembering that securing those ABCs, airway, breathing, and circulation, in conjunction with administering naloxone is critical in the response to overdose events. It is true that the naloxone injection is more efficient than the nasal spray. So this is an opportunity to advise patients on not mixing drugs if possible, staying hydrated, and seeking medical attention quickly, even if you have nasal naloxone on hand. Second, we have SSPs, or syringe service programs, also illegal in Texas. They offer more than just clean syringes for people to inject with and a way to dispose of sharps. Some have hepatitis vaccines and testings, HIV testing, and provide PrEP. Remember, there are multiple steps in the process of injecting heroin that are prone to contamination, not just in the syringes, but also in the filter, and the cooker, and the skin entry point. And it's important to advise patients of sterilizing on each step. Other forms of harm reduction include fentanyl and xylazine test strips. Currently in Texas, there's a bill to decriminalize fentanyl test strips that passed in the House, but not yet passed in the Senate as of early May. It's usually people on opioids know that there's fentanyl in their supply, so these items are a little bit more for people who use substances such as stimulants, who aren't expecting fentanyl in their drugs. Note that utilizing a fentanyl strip requires sacrificing a good bit of that drug supply you already have to ensure that it's free of contamination, so this option isn't always popular. Other forms of harm reduction include wound care services, sterilized pipes, print material on how to responsibly dose substances. So advocating at the community level for expansion of these services is really important for our patients. All right, next slide, please. So if a patient is not ready to talk about quitting or reducing their drug use, acknowledge that there's probably legitimate reasons why the patient uses drugs, that the drugs are probably serving them in some way at this moment in their life, and that they just can't envision themselves in treatment or recovery at this time. And give them space to have that viewpoint, because it is very valid in the face of the things that are in society today that drive people to use drugs. Next slide, please. There is good evidence that harm reduction works. Harm reduction strategies have shown decreases in overdose mortality in various settings. There's estimates that SSPs can lead to 60% decreased incidence of HIV, as well as decreases in HBV and HCV transmission. Patients using syringe service programs are much more likely to enter drug treatment and stay in it. And there's healthcare cost savings as well. In the media and political sphere, there's a lot of scrutiny on harm reduction for a few reasons. Many established recovery centers that promote abstinence and decrease drug use believe that their mission is at odds with harm reduction. And some people in the recovery space can weaponize their recovery and exclude people who may have different goals, maybe due to the belief that if I can be abstinent, so can they. Additionally, harm reduction is often misunderstood as a practice that enables more drug use and discourages treatment, though there's actually no real evidence to prove this. And others believe that drug use is a choice and a moral failing, that the appropriate response is punishment. And still others try to emphasize the dichotomy between hard drugs and more socially acceptable and sanctioned drugs, such as psychedelics, as a way to shame and dehumanize people that use differently from them. And then finally, the establishment of such harm reduction services can impact the character of an urban space. Thus, NIMBYism drives some of this resistance. So these are all toxic and pervasive ideas that the patient has certainly experienced before. So if they do bring up any of these concerns, such as feelings of guilt or fear of punishment or stigmatization, you can point out that while their unpleasant experiences are valid, messaging from these institutions on how to approach recovery are not really based on fact. Everyone's road to recovery looks different, and there's no shame in seeking help. So validate their personhood and encourage them for even taking that first step to even inquire about their options or how life could look better for them. Next slide, please. Another reason that a patient is pre-contemplative in that moment is because they're in acute withdrawal. Many of y'all know this, but here's just a review of some of the medications that can be used to ease the immediate symptoms of withdrawal, the non-opioid medications before you even induce butyl or methadone. If they're also presenting an acute pain on top of the withdrawal, say from an abscess or a fracture or trauma, it is appropriate to treat that pain with full opioid agonists to address both the analgesia and the alleviation of withdrawal symptoms, while thinking about a long-term strategy a little bit later. You can say, you're in tremendous pain. Let's get that taken care of first. Here's what I'm going to make available for you to help you through this, and actually make yourself readily available for them. Remember that if you're starting a full agonist on these patients, they will need to be at higher doses. So at least start with double what you would give a typical patient, have generous PRN doses, frequent reassessment, and a low threshold to escalate to a PCA or switch to something else if it isn't working. This is a really important part in the process for establishing that therapeutic alliance. If you're saying that you're going to treat their pain and then start Oxy 5Q6 and then kind of run away, this kind of undermines your relationship with the patient. Remember that even methadone or long-acting opioids can be used to stabilize acute pain, even if you're not intending for a long-term strategy with it. So after you've somewhat stabilized their acute distress, they may be more willing to engage in discussion about treatment. Next slide, please. So if we go back to our stages of change, how would we counsel the contemplative patients, the ones who are interested in hearing more? Next slide. Committing to treatment with bup or methadone also means committing to regular follow-up, at least in the short term, to ensure that the medication is serving the patient's needs and allowing for adjustments. Treatment can be enhanced with counseling and other forms of support, but you can pursue treatment with just medication as well. Buprenorphine, as we all know, is a medication that reduces opioid mortality, overdoses, bloodborne infections, and increases patients' likelihood of engaging and staying with treatment. So what do we tell patients? It is an opioid, but safer. It'll help with both your symptoms of withdrawal and pain and reduces cravings. There's different formulations of it, including sublingual tablets, ER injections, and sometimes the buprenorphine is complexed with naloxone in tablets and films. The naloxone component theoretically shouldn't have an effect on you if you take the buprenorphine by mouth, but a few patients can experience very mild withdrawal symptoms from the naloxone formulations. Because of the pharmacologic properties of buprenorphine, there is a ceiling effect to it. So it basically prevents you from dying if you take too much. Methadone, an older medication, is a full agonist and may be more effective for someone with really severe dependence, really severe pain, or high daily needs of opioids. The ceiling effect doesn't apply as much for methadone, so it is still possible to overdose from taking too much. And access to methadone is highly regulated with long waiting lists at methadone clinics and the stipulation that you have to go to a clinic every day and submit to a urine test for at least a year to receive your dose. It also can't be prescribed by the hospital. In general, it tends to be cheaper and has slightly higher treatment retention rates. And there does tend to be a little bit stigma around methadone treatment. Tapering off methadone or switching from methadone to something else takes a longer time because of its long half-life and long withdrawal window. Next slide, please. Other things that will certainly come up when patients ask you, questions, is the fear of precipitated withdrawal with buprenorphine. You're slightly at more risk in the age of fentanyl of precipitated withdrawal, but it can be treated with high repeat doses of buprenorphine. I think we're going to discuss later in the case today, as well as adjunctive medications, or microdosing while continuing a full agonist until the bup reaches a steady state is becoming more popular. Some patients might say, isn't this replacing one addiction with another? Remind them that addiction and physical dependence are not the same thing. So in the same way that people with diabetes are dependent on insulin, people with OUD can be dependent on bup and methadone, and that's okay. It's not a bad thing if the person is taking the medication in a controlled and prescribed way without the cravings and the lower quality of life and risk of dying that's associated with the chaotic use. It's a really good thing that the patient is seeking a safer and healthier way to live their life. Some patients may say, I just want to detox and be off of it all, off of all substances. Unfortunately, detox for opioids just doesn't work for most people. 80% of people who detox return to use in less than a month. The situations and circumstances in your life that lead to drug use, unfortunately, don't change overnight, even if every trace of the drug and symptom of withdrawal has left your system. So this is why other therapies like counseling and peer support can be helpful during the beginning of recovery. There is a stigma associated with being on treatment, and that you can experience at pharmacies, healthcare settings, and in the workplace. But the risk of experiencing stigma may be worth it if we can lessen your chance of dying. You may get the question, what if I come to the hospital for another reason and I'm in pain? Does that mean I won't get treated for pain or pain medications won't work? No, you can still be treated for pain with full agonists. You may or may not need dose adjustments of your buprenorphine in this case, but it can be managed. Next slide, please. So then we come to the action stage. When a patient has decided to start treatment, we should coach them throughout the entire process. It's important to utilize shared decision-making when coming up with an induction plan for them to take into account what feels feasible for the patient and lessen some of their anxiety that may be associated with the treatment by giving them agency. So ensure that you're on the same team as the patient. We'll be on hand to closely monitor the response to treatment on an hourly basis, tackle any side effects or issues that may arise, and pivot to another plan quickly if the current one is not working. Next slide, please. I won't go into the details of these since it has been covered in other didactics throughout the year. Suffice to say, there are both macrodosing and microdosing protocols that can be done in outpatient or inpatient settings, and you and the patient can decide what's feasible for them based on their symptom tolerance, length of stay, last use, and the formulations that you might have available in your pharmacy. Remember that if the patient is experiencing acute pain in addition to withdrawal, it is appropriate to treat with a full agonist therapy until the acute episode is stabilized, and then talk about starting induction. In the first few days of being on bup, you might feel intermittent symptoms of withdrawal as the other opioids slowly leave your body. You may also feel some side effects from buprenorphine, such as sleepiness, nausea, dizziness, as your body kind of gets used to the new med. And usually after that acute period of withdrawal is over, your daily dose can be tweaked up or down to what your body needs to stave off those cravings. You will have PRNs available to you to help manage some of these symptoms during this time. Next slide, please. And finally, we approach the other end of the spectrum of stages of change, the action and maintenance stages of MOUD treatment. Next slide. For maintenance, it's generally important to stay on treatment for at least 12 to 15 months and probably indefinitely. Remember to maintain your other support structures as needed during your recovery, such as your family, your advocates, peer coaches, membership in groups, sober living, and regular access to mental health and primary care services to address your other medical issues. These aren't necessary to, but can enhance your recovery. If a patient asks about finishing treatment, never discontinue treatment without the assistance of a healthcare provider. Discontinuation of treatment, even after more than a year, can lead to increased risk of relapse, readmissions, ED visits, and overdoses in the first 6 months. These risks decrease a little the longer you continue on buprenorphine, but never completely go away. If you do return to use during the course of your treatment, if you have buprenorphine still in your system, because of its strong binding affinity, you may not feel the effects of heroin or fentanyl the way that you used to, because it is hard to displace the bup from its receptors. That's not to say it can't be displaced if you use enough, but obviously that carries a significant risk of poisoning yourself. Don't be too hard on yourself if a relapse or return to use does occur. We are always here for you to help you through it. So essentially, meet the patient where they're at, be there for them through probably one of the worst days of their life, and just be kind. And that's all I have.
Thank you so much, Jan, and for persisting through those tech challenges. We're glad you came through loud and clear. Any questions about that didactic? Well, I was glad to see, and thank you for pointing out the point about precipitated withdrawal. I think that'll be really applicable to our conversation a little bit later on when we get to the case. If questions do come up, feel free to unmute or share those in the chat. At this point, I want to pause and do some announcements from the CSTAT program. Carly, when you can you share those slides? Great, thank you. So the Center for Substance Use Training and Telementoring, or CSTAT by Be Well Texas, provides high quality education in best practices for responding to substance use. CSTAT can help enhance professionals' knowledge and self-efficacy to screen and treat and make referrals for people with substance use disorders. So to learn more, visit cstat.utesca.edu. We'll throw that link over in the chat. Next slide. And in case you missed this, a very important announcement for addiction specialists and healthcare professionals. The FDA has approved Brixadi extended release injection. That's buprenorphine extended release injection, subcutaneous use under the skin to treat moderate to severe opioid use disorder. So it's available in a couple different formulations, weekly and monthly, and you can visit the FDA to get a little bit more information about that. Carly's dropped that link over in the chat if you want to learn more. Next slide. And don't forget, these sessions are eligible for continuing education accredit. To get your CMEs, you need to text this code in red to the phone number there by midnight tonight. So just a text attend and then those digits to that number. We'll throw that information over in the chat. And we found it's better if you don't put any spaces in between the digits for the CME code. And next slide. We do hope you'll join us for our next Echo in this series in July on the 20th. We'll be featuring a presentation on effectively influencing change by a member of our hub team, Chris, who's also joined us today. And I think that's all I have in terms of announcements. At this point, Maddie and Dustin, we'll turn it over to you to take us through the case for today. They'll talk us through the case, bring up their questions for the group, and then we'll close out the hour with open discussion. Again, we encourage everyone to share their questions, share your experiences and your feedback today. Maddie, Dustin, when you're ready and you see that case, take it away.
Thank you, everybody. Actually, Dr. Demas is still in clinic, so I will be presenting the case. He might come in at some point, but otherwise it'll be me.
Totally fine. Thank you.
Yeah. Okay, so today we're going to present a case about precipitated opioid withdrawal, as you mentioned. This is a case of a patient that actually presented to our Bridge clinic. So the patient was never actually medically admitted. They were seen in the Bridge clinic and then in the ED, as you'll see as we go through the case. But the questions that we'd like to address by our community. Or do you want me to present the case first? Sorry.
You know, whichever feels more natural to you, but we want to make sure we hit on those questions. So
okay, let's go with the case and then we'll come to the questions then.
Perfect.
So this was a 31-year-old female who came into the Bridge Clinic to start treatment for her opioid use disorder. She reported that she had been using fentanyl-laced oxycodone for about 9 months. She took about 4 to 5 pills per day. And she last used about 15 hours prior to arrival. She took about a quarter of a pill. She was evaluated and her initial CAS score in the Bridge Clinic was 16. So they determined that they would do a macrodosing approach with the patient, and she was given 8 milligrams of buprenorphine. She was seen again 40 minutes later. Her CAS continued to be elevated at 15, and she received an additional 8 milligrams of buprenorphine at that time. She was seen 30 minutes later by the provider. She received clonidine 0.1 milligrams and 1 gram of Tylenol. And then 75 minutes after her second dose of the buprenorphine, she was reassessed. Her CAS was still 15, so she was given a third dose at this point. About 45 minutes later, her CALS was still elevated. I don't have an exact score, but she was determined to require a 4th dose of the buprenorphine at 8 milligrams, as well as Zofran 4 milligrams. And she was referred to the ED because it was determined that her symptoms were not improving. She was, getting very sick, and she was in distress. A lot of the medical history was, there was not much relevant medical history. She had a history of a unspecified depressive disorder, but I think there was also some information that was not obtained because the patient was in distress. So they mainly wanted to focus on stabilizing her withdrawal symptoms. Once she was in the ED, she did receive additional doses of buprenorphine, which we'll talk about, as well as IV Zofran and IV fluids. It did seem like her support system was very limited. She had no family support. She reported living in a house with a friend, using public transportation, not owning her own vehicle. And there was a history of an unspecified depressive disorder. So the patient was sent from the Bridge Clinic, which is actually in our urgent care here at JPS. So she was sent over to the ED, which is just across the street. And her CALS score on arrival in the ED was 14. So she was actually given an additional dose of 16 milligrams of buprenorphine at once. She also had a CBC, CMP, lipase UA, an abdominal sono, and a respiratory pandemic panel performed. All of the results were normal. And she was kept under observation in the ED for about 5 hours, which with improvement in her symptoms. I don't have a final CALS score, but it sounds like at the end of her observation period, the patient was comfortable and felt safe discharging home. Overall, from time of arrival to the Bridge Clinic to discharge from the ED, it was about 12 hours. So she received a total of 48 milligrams of the buprenorphine in 12 hours. She was discharged home with a prescription of, this should say Suboxone, 821 milligrams TID for 2 days, and she was given specific instructions to come back to the Bridge Clinic tomorrow or the next day. Her PDMP didn't show any pertinent findings, and our main concern, outside of the fact that there was, it was distressing for the patient, is that she also did not return for follow-up. Again, a lot of her history was not, it was not documented, though as far as we know, her only primary substance that she was using was the fentanyl. We can go back up to the questions. So about this case, I think just poses multiple questions, but mainly we wanted to talk about how clinicians are effectively counseling and or engaging patients that are currently using fentanyl and that know that that is what they are using in treatment with, and again, that should say Suboxone. We also want to ask what treatment protocols are other clinicians following to prevent precipitated withdrawal in patients that are primarily using fentanyl. And for patients that have experienced precipitated withdrawal, what strategies are clinicians or treatment teams using to re-engage the patient in treatment?
Great, thank you, Maddie. I actually don't have much to add on to that. We'll go right to questions, really well presented. Any questions or thoughts from the hub or the rest of the learning community? Maddie, could you just help me understand a little bit, sort of what structures are in place already to support follow-up? It sounds like the patient not returning was one of the big challenges or concerns here. What's the system like currently that encourages or reminds that person to come back?
So the patient has, because she was seen in the Bridge Clinic, she did make a connection with the case management team there. And she, her treatment was discussed with a provider there. And this was reinforced when she arrived in the ED as well. And her chart review does show that there have been attempts made to call her and ask the patient to return back to the bridge clinic by our case management team.
Thanks for clarifying that. Abby and Megan, you dropped something in the chart too here. I wonder if you might just unmute for those who aren't not in the chart, in the chat. I wonder if you might unmute and share a little bit more with the group.
This is Abby. We had a case recently. Oh, sorry.
Go ahead, Abby.
Okay, we had a case recently where someone tested positive for fentanyl, and I wasn't actually there. I heard about it. It wasn't a patient of mine, but they tested positive for fentanyl, had precipitated withdrawal, and they decided to instead just kind of buy some time by giving like short-acting full agonist pain medications, and doing that for about a day or so, and then doing an induction kind of so that it's more predictable that the fentanyl was out of the system, hopefully by the time. So that's like another option, I guess, for potentially managing it. Like, I don't know if anyone else has other ideas.
Yeah, Kristen, I see a hand up. Kristen Clancy, you want to unmute and share? Try that. While we're working on that, Megan did drop something in the chat. Megan, I'll just read out what you mentioned because the mic's not working. Zoom is giving everybody issues today. But anyway, Megan shares in the chat, I've been having patients with fentanyl use wait 24 hours before starting buprenorphine products. The ones who really wait the 24 hours seem to have an all right transition without precipitated withdrawal. Kind of open up that to the group and get some thoughts on it as well.
We do a lot of that, in the hospital, opioid bridging. I think we're going to see more and more. It's just so potent and it stays around so long. And I think the problem for you guys is you're a bridge clinic and you want to do something now. I'm curious, I don't know how feasible it is to say, here's a prescription for full agonist opioid, come back tomorrow. Don't use fentanyl, just don't use fentanyl. Here's this. And I can see the tension and concern about doing that. I have myself, I let a patient choose to do, had overdosed on fentanyl the day before, was still kind of fine. It had been 24 hours, but didn't have any symptoms yet. And he just said, I just want to do it. Let's go. And had almost this exact story. We were using buprenorphine naloxone strips. So this was like literally last week. Almost this exact story. We didn't, he was in the hospital, so we're not transferring him anywhere, but it was just this frustrating thing where I basically lengthened stay when I could have just discharged, helped them discharge him right then and given him a prescription and said, start this when you have symptoms of withdrawal. And he ended up going, I think we went up to like 40 milligrams of buprenorphine. It ended up kind of cooling off. It was just hours of having it in his system. I really liked what you did with augmenting with alternative agents. And that's what we started doing too, which was get clonidine going. What else can we give him? We actually gave a little bit of Ativan too, and that seemed to kind of settle down how he was feeling and at least tolerate it. And it all seemed to kind of go away within 4 or so hours once we kind of got up to like really significant dosing. And then he still that evening, that was around by like 5, 6, 7 p.m. That evening, he still took an 8-strip of buprenorphine and he left on TID the next morning and was doing fine. And just kind of went through the ringer. What was nice about that case was that next morning, how apologetic I was about, I'm so sorry, like you went through a rough ride. He actually said, yeah, but like the real withdrawal would have been way worse and last a lot longer. So it was okay. Like I was here, you guys were helping the whole time. It ended up, I felt terrible. He was kind of okay with it. So I think one thing is, sort of kind of preparing patients for that risk. I think what's interesting with your case too is that their CALS was a 16. You know, they had withdrawal already, right? If I remember that correctly. And I'm curious if other people are starting to see this kind of pattern. Has anybody seen that where they've got folks who've, you know, been using fentanyl, they've used it fairly recently, their CALS is pretty high. Are they still having kind of trouble initiating the treatment, getting people on Suboxone?
Anyone seeing that or experiencing it want to share the challenges they faced or strategies?
From what I've seen in the hospital setting, I think fentanyl is the rule rather than the exception. And so it's almost become a rule for me to use full agonist bridging treatment before doing the induction. But that's also knowing that the patients that I see are usually presenting with an acute complaint as well, with some sort of trauma or an abscess or acute pain that needs to be treated. So I usually always do like a full agonist first before inducing. But I think also the idea of waiting that 24 hours and using the adjuncts is helpful. I actually do use Ativan a lot too.
You know, the other thing is, do you guys ever do microdosing, like send with a script for microdosing, keep on using your fentanyl, and here's your microdose plan for the next few days and come back and see us in 2-3 days?
So in the hospital, we do use microdosing. You know, generally patients are admitted for other complications as well. So we have the time to try to treat with microdosing. The Bridge Clinic, I know that there has, or actually, I don't think it was the Bridge Clinic. I think it was our START Clinic, which is our MAT clinic, has had, I think, one patient that they have discussed microdosing. But with this, you know, whole idea of like them using fentanyl, I know that that's difficult and scary.
So it's actually, it may be scary. I mean, we're scared of people using fentanyl. Our patients on the street are using fentanyl. They know they're using it. They know how to use it. Obviously, it's higher risk for overdosing, but they're already using it. So there are absolutely very available outpatient protocols for microdosing to continue what you're using. So you might look at that, because maybe the Bridge Clinic would, especially when you have patients who are like, afraid to start that day, afraid of precipitated withdrawal right now. It's like, well, okay, let's give you just a tiny microdose. You can see what it feels like right now. Right. And here's your prescription for your microdose protocol. They're usually like 3-4 days of, you know, they quarter their strip and take it 4 times a day of the 2 milligram strip. And then the dose doubles the next day, and then it doubles the next day. And all the while they're supposed to continue to take fentanyl or whatever it is, their supply. Now, you don't always have a patient that has access to a supply. Like, there's obviously, it's very patient centered and dependent. But that is well described, used across the country. I don't do a lot of outpatient work, but I'm curious from you outpatient docs who are on here, are you guys doing kind of outpatient microdosing options? Because maybe that could have been an option for this patient. Or other patients who aren't in withdrawal yet, but want to have it sort of in their back pocket to get going. Some people are saying, I've never had anyone successfully follow a microdose plan on their own with at-home management. And another mention was about low-dose ketamine. But I think I may have missed some of the context.
No, that was me. And I had worked with somebody who, obviously I'm not a doctor by any means, but I worked with somebody who had gone through some like pretty severe opioid withdrawal from that. And they had used the low dose ketamine, and they said it helped substantially.
Does anyone have any input about kind of rising evidence for low dose ketamine as an augmenter? I haven't used it much myself, but there has been increased mention of this in the community?
I believe the California Bridge Project has started using low-dose ketamine for refractory precipitated withdrawal after repeated doses of buprenorphine. Thank you, Dr. Clancy, for inviting me to this. My name is Dr. Andino, y'all. I'm at UT Southwestern. Pleasure to visit with y'all about this. Just wanted to chime in. Primarily, we've been waiting more than 24 hours to start these patients when we hear that they use fentanyl. Also, we wait for a CALs typically greater than 12 to 16 and start with anywhere from 12 to 16 milligrams of bupe and have had still precipitated withdrawal, but have given repeated doses of 8 milligrams up to the 40s like this patient and had some pretty good success.
And Dr. Andino, is this like in a hospital, or is this, these patients like outpatient?
These are patients in both in the emergency department on the inpatient ward. And typically we reserve the more stable patients for a clinic.
I was gonna say, I think that maybe, something we've talked about or thought about after this patient is, obviously the outpatient approach, microdosing, but also maybe if we had the ability to continue to observe her overnight, to treat some of those, to have allowed her to have more adjunct treatment while we were working up to these higher doses, and just continue to observe her maybe in our clinical decision unit and, get her through the night. Maybe would have been able for her, she gets through it and we can still continue treatment after that. But I think she felt stable enough to go home, but it's just like, it was very traumatic and distressing for her. So I understand why we haven't been able to reach this patient again. Do you guys have any idea about that, about how, what other types of ways we could reach back out to our patients, even while they're still with us? Like what kind of language or what kind of approach we can take to re-engage them and, express that we still feel like they could be successful in treatment?
Lindsay, yeah, go ahead.
Yeah, so I always advocate, I think every time we're here, for, the inclusion of peers in your programs, because peers are really, especially if they're, you've got somebody who's kind of had a hard time, having them be able to relate to that person and really talk through them. And then, not only that, but continue to talk to them throughout the day, because I know our peers reach out I know that peers can reach out to people, multiple times throughout the day. They can have longer sessions, they can go meet people where they're at, like help them, maybe even give them a ride home so that you know where they are, things like that, and then do that active like outreach and engagement.
Yeah, I wanted to chime in that the part of the reason that I'm really appreciative of any input here is in our bridge clinic, this Jim Nityan at JPS as well, is we've seen a handful, and we have waited till their COW score is higher, counseled them in that. We do have peers, and when we transition a patient from the bridge clinic to the ED, the peer, when available, goes with them and stays with them as long as they can. The period of time in this case, I think this one patient was 15 hours total in our care, which, as Maddie alluded to, we're engaged now with our observation unit as to would this have been an option in the future. But up until about a month and a half ago, we had no or very few precipitated withdrawals at all. And those were always based on somebody recalling after taking the buprenorphine that their timing was off. Prior to the last couple of months, we didn't seem to have nearly the same problem with precipitated withdrawal, and we suspect it is the fentanyl. We are waiting longer. We are asking for a higher COW score, but it's looking like, as you guys have alluded to, we're going to need a combination of medications to get them through it, or we're going to have to consider how to get people into microdosing with limited resources, because we're not using strips. We're just using the sublingual tablets due to cost in our public facility.
Yeah, and it's much harder to microdose with the tablets because they just sort of disintegrate. Yeah, and I think it's a real problem because who on earth can wait that long or longer? I feel like it's kind of an unreasonable expectation. We would never do that in the hospital. We have the luxury of full agonist opioids so that people aren't entirely miserable. It's really frustrating. I hate fentanyl. I wanted to ask anybody out there, I don't know if you see the chat, but does anybody know doses of ketamine you're using? Anyone using it? It's so out there now because, they've approved everything, that it really is available, and it probably ought to be added to some of our wheelhouses, certainly mine in the medical hospital for sure. So if anyone knows that, what other, ooh, nice. Something just popped in the chat.
Great chatting, Joanne.
Yeah. Yeah, okay. So this is microdose. The tabs are Bupe, I think. Feel free to jump in. I know we've had some trouble with technology where people can't speak. Yeah, so definitely if they're using pills of any kind, which may be pressed fentanyl pills, then keep on using them. But I would look at Penn has a good outpatient microdosing protocol that's really easy to follow. And that may end up being one of the main things that's actually available to patients who can't wait. I will say also, I know some of the question is how do we retain patients and they leave and they never came back and they were too afraid to try the kind of microdosing protocol. And I think all we can do is just keep on trying, being very open, patient-centered, apologetic when you precipitate withdrawal. I'm so sorry you're going through this. I know this is tough, but also it's, I think we just do the best we can. I blame the fentanyl and I'm in it with you kind of thing. I'll bet you guys are doing an awesome job of reaching out and retaining your patients. I think all you can do is sort of do the best you can and try to help as much as possible. I don't know if other people have thoughts about that. I love the idea of, more reaching out, that peer support, kind of helping and going with patients is amazing. I wish we had programs like that where we are.
Also incentivizing it, right? So, not necessarily with like money or gift cards, but just incentivizing it with offering them, I don't know, food or, a safe place to hang out or, having that really kind of friendly, open environment can be helpful to bring people back. Even providing we used to give people cups of ramen or like cups of, just some type of food or something. And then for people who are unhoused, we have homeless kits, right, that we can hand out with like toiletries and things like that.
That's a great idea, Lindsay, because how do you just getting them back in, I feel like, and then it's sort of a warm hug approach once they're there to kind of help them get help in all the angles that they'll let you help them.
And this is somebody who's facing transportation challenges too. So yeah, they could have every intention and will to come back, but those are hard barriers to come around. Yeah.
And up where you guys are, do you have help with that? In Austin, some of our clinics do have support for transportation, like same day of appointment kind of thing. Folks can call the clinic and then they send a lift. So I'm wondering if y'all have any programs like that yet in your area, but that might be something to explore.
Doesn't Be Well offer that? Like a Lyft, they have a Lyft partnership, I think.
Yes, but I'm not sure if it extends up where you are, Maddie. And I see, Jim, you unmuted. We're coming up on time, but I want to hear what you both have to say.
Just wanted to say our peer navigators and case managers can arrange transportation both to our START clinic, our Bridge clinic, and other arrangements as needed. So yes, we can arrange transportation.
That's terrific. Well, yeah, thanks for sharing that resource. Maddie, thanks for the for presenting this case today. I think we've learned a lot and hopefully have shared some strategies that are helpful. Polly noting in the chat that also giving out bus passes is another tool or strategy. Jan, at this time, I'm going to come to you for a summary of some of our key points from today's conversation.
Sure. Thank you, Maddie, again for presenting this case. We had a really great discussion on precipitated withdrawal that's becoming, unfortunately, more common in the fentanyl setting. And we discussed strategies such as microdosing with full agonists, waiting 24 hours for those who have the luxury, and using adjunctive medications, coaching the patients through it to try to get them through the withdrawal. Some other ideas that came up are using ketamine and peer recovery coaches for an extra source of support. And then it'll become really important to re-engage the patient with care if they had a traumatic experience with precipitated withdrawal. And we talked about strategies to reach them where they're at with transportation, again, with peer coaches, and then keep trying again and validating the experience that they're going through and continuing to congratulate them on any step they make towards recovery.
Great summary. I want to thank you all for joining us for today's session. As a reminder to earn those CAE credits, text the code listed in the chat to the number we provided. That's 1009295 to the usual number. And also please do complete the post-session survey Carly's dropped in the chat a few times to help us shape the series moving forward. Thank you, Jan, for the great presentation today. Thank you, Maddie and Dustin, for submitting and sharing this case today. And as always, thanks to everyone who keeps showing up to these sessions to make them the learning environment that they are. We'll see you in about a month at our next session on Thursday, July 20th. Have a great rest of your day and rest of your week. Bye-bye, everyone.